thank you for having me. Not a doctor yet,
Oh,
but
sorry.
working on it.
Actually might be, there we go, sorry. Keyboard will be better. Is there a way to?
I'll read it from here, that's okay. So when we think of parenting, we perhaps hope for the roses and the picture-perfect role that Beyonce presents here. However, it might not be surprising to you to hear that most parenting stories are not aligned with Beyonce's experience. And while parenting brings many joys, it is not without challenges and heartbreak. I've been working as a nurse for almost 30 years, and for 24 of those, I have been working at the Royal Children's Hospital in a variety of nursing roles. For the past 9 years, I've been working as a clinical nurse consultant in the Department of Neurodevelopment and Disability. My team cares for children who have the most complex neurodevelopmental disabilities, and my role is to support children and families to have the best health that they can. For children, I coordinate clinical care and provide assessment and care plans via the phone and in person. And for parents, I work together with our team psychologist to deliver the Parent Wellbeing Clinic, which is specifically designed to support parents' mental health and wellbeing who've got children cared for by my department. Keyboard. Okay. Like all nurses at the Royal Children's Hospital, I am focused on family-centred care to promote the health and well-being of the whole family. The International Council of Nursing has said that nurses are health professionals who are closest to patients across their life course. We stand alongside people when they are at their most vulnerable. We are privileged to be trusted with all aspects of people's lives, their joys, their challenges, their griefs and sorrow. It is through this shared journey that nurses develop a unique perspective amongst healthcare providers on what can be done to improve the experience and health of the families that we care for. My role is to be there to support families with the day-to-day care of their children and to make sure that I'm doing everything I can to contribute to a system that provides holistic and equitable care. When you've worked in a field for as long as I have, you find there are children and families whose stories stay with you and who shape you as a clinician and a person. Noah and his mum are two of the people that I have cared for whose experience helped me decide to study respite and in-home care support. To help explain why this research is so important, I would like to share a little of my role with Noah, but with his mum's permission. Noah was diagnosed with Niemann-Pick Type C as a young boy. He was cared for at RCH by the metabolic team. However, when his level of disability progressed and his health started to decline, he was referred to the neurodevelopment and disability team for additional supports. I met a lovely young boy with the best smile and a truly gentle nature. During Noah's time with my team, his condition progressed and he needed to have regular suction, tube feeds, and constant supervision to ensure his safety, particularly as his seizures worsened. The progression in his care needs was fairly rapid, and this level of care is far beyond what we would want to ask of any parent to provide for their child at home. In Australia, parents are expected to provide this care in the home, but with some difficulty can get access to support workers through the NDIS for additional support. However, the road to this support is particularly onerous for parents who must dedicate significant time and energy to applying for NDIS, and then if successful with their application, they recruit, train and manage support workers. I remember Noah's mum calling me, distressed as she was providing 24-hour care for Noah to keep him out of hospital where no family wants to be, largely without support, or with support workers who are overwhelmed with Noah's care needs and fragility. Noah's mum fought so hard to get Noah the expert care and support he needed at home, and it took up time that she should have been able to dedicate to spending with just being a mum to her beautiful son. It struck me then that surely we must be able to do better for families. Surely we couldn't expect them to do this without the right kind of supports. However, when many families apply for in-home support through NDIS, they hear the words parent responsibility, or routine parental care. This is an example of an email I received when trying to support a family to get access to respite. Please remember that the NDIS consider that any child is a responsibility of the parents, so it's unlikely that they will approve respite. It is through supporting Noah and other children with similar care needs to Noah that I have come to see that the current system available does not understand and consequently cannot meet the care needs of children with disability and medical complexity. As a clinician, I can see areas where improvements are needed and could be delivered at little cost to the government. However, there is very little research in this area, and without research, we do not have the evidence to make sustainable and effective changes. When I refer to respite during my talk, I'm actually including in-home support and any out-of-home support that provides primary caregivers with a break or support to care for their child. There is a lot that we don't understand about respite for children with severe neurological conditions and how it intersects across parent, child, provider, and system. So through my PhD, I am exploring formal respite care for children with severe neurological conditions in Australia. I want to understand the parent, provider, and child experience and to identify the enablers and barriers to respite care. I'm also hoping to explore practical and psychosocial training and support needs for parents and providers, as this is where much of my clinical experience lies. So far, I've undertaken a scoping review, which is a literature review, to look at the currently available research and literature. I'm currently undertaking interviews with parents, which I will follow with interviews with the workforce, and then examine issues at a system level. Finally, I'll bring all of this together to critically analyse how the layers intersect and how we can strengthen the overall experience. My scoping review sought to understand the current available literature of the experience of parents who receive respite and providers who deliver respite for children with severe neurological conditions. Through a comprehensive search of the healthcare research and other literature, I found 10 studies that met my inclusion criteria. 7 of the 10 studies were completed with parents only, and a further 2 studies were completed with both parents and providers, while 1 study was completed with providers only. 593 parents and 64 providers participated. Providers included 8 disability support workers and 76 care coordinators. This lack of research, particularly with disability support workers, makes it difficult to make any conclusions about parent and provider experience of respite care for children with severe neurological conditions in Australia. Using inductive content analysis, I identified 4 themes from the available research. Trust has previously been identified as an issue for parents using respite, and my scoping review further adds to this knowledge by identifying the elements of trust that parents require of support workers. The process to trust is nuanced and develops over time. It needs a consistent worker in order for trust to occur. Parents want support workers to connect with the child, to treat them as a person, and to learn about the child first and the disability and care needs second. Parents need support workers who listen to them, fit in with the family, and are flexible with the care they provide. Parents felt that having a formal qualification did not contribute to trust in the home setting, and possibly prefer workers without a formal qualification, as they are more likely to listen and be flexible and not be constrained by a scope of practice. However, for families who use community respite, they liked having a qualified healthcare there, such as a nurse, as this increased their level of trust when leaving their child. Organising and using respite can have positive and negative impacts on parents' emotional and physical well-being. Parents experience guilt and worry thinking about and using respite. Having a support worker in the home disrupts normal family life and interferes with the ability to relax. Parents and providers both recognise the benefits that respite has on health and well-being and relationships with other family members. Parents worried that the workforce would not be able to accommodate their child's behaviour and medical complexity, and that this would cause the child to have a bad respite experience. All providers need training from parents to look after the child safely. Parents experienced a physical and mental burden of training. There is a recognition amongst parents and providers that as medical complexity increases, accessibility to a safe respite experience decreases, as staff do not have the right emotional and technical skills, experience and knowledge to meet the child's health and psychosocial needs. Lastly, a lack of specialised equipment such as hoist and feeding equipment meant that many children couldn't access community respite. Often parents don't know about respite until they met with a provider who told them what was available. Both parents and providers were aware that there are very limited options for respite for children with complexity, and you can't experience respite if you can't get it. Parents felt judged by providers, but felt reluctant to voice concerns in case they lost what respite they did have. Parents wanted to feel heard, respected, and acknowledged as experts in their child's care. However, they did not feel this happened. Conversely, care coordinators felt aware of parents' needs, but experienced powerlessness to support parents within the constraints of their role and experience. I am currently interviewing parents about their experience with respite and in-home care support for their child. So far, I've interviewed 15 parents of 13 children. To start the interview, I asked parents to tell me what their child likes to do or what they like to do with their child. I've heard wonderful stories of children who like reading, art, music, swimming, going for walks, but most consistently I hear of children who are social and who love to be with their family and with their favourite carers. Children in this study have a wide range of diagnoses, but most commonly to date have cerebral palsy or a specific genetic diagnosis. All are using in-home support funded by the NDIS, and 4 have used respite care through Very Special Kids, which is the Victorian Paediatric Hospice, which provides limited amounts of respite to eligible children. Most families had between 1 to 5 other children living at home, and 5 families had other children with other types of medical or neurodevelopmental diagnoses. All of the children need some communication support and didn't use words to communicate. There was one child that had some verbal language that their primary carer could interpret. Care needs of the children were many and varied, but primarily involved mobility support, continence care, supervision, tube feeding, and seizure management, which are some of the concerns that I hear a lot through MPC. I'm still in the process of interviewing and analysing the data, so I don't have any official results to tell you about yet. Instead, I thought I might give you an idea of the kind of things I'm hearing from parents. One of the main ones, which might not come as a surprise to many parents here, is that there's a huge amount of variation in the system. And by that, I mean the NDIS and also within the actual support worker system. While all of the children have a similar need for supervision and medical care, there is a huge variability in allocation of hours within the NDIS. And at the moment, many families are actually losing hours they previously had, while others are getting more hours of support work. Some NDIS assessors seem to understand the child's needs, but most are not familiar with the level of disability and medical complexity. Families are frequently told that the child's care is parent responsibility, and many families have described having to justify why each of their extended family members, such as grandparents or other siblings, can't provide additional care for their child. When navigating the NDIS and also recruiting, training, and including support workers, parents describe a journey where they learn over time. Parents have talked about not knowing what they can ask of support workers and spending time cleaning the house and making everything ready before the support worker arrives. However, when there is more familiarity and they get to know and cherish the support worker, then they are more comfortable hanging in their pajamas and showing how life really is. Families have all experienced less than ideal in-home supports, and on some occasions, support that has put the child at significant risk. Parents don't know how to manage a workforce and seem largely unsupported to address areas of concern. However, when the family find the right support worker, they become part of the family and seem to have a significant benefit to the child and also to the parent well-being. Fortunately, most families I've spoken to have found at least one support worker that they trust and value like a member of their own family. All parents talked about experiencing difficulties with recruiting and engaging the right support worker. However, the common message that they want to share with other families starting in this journey is not to give up. As one dad said, and then we thought like, oh, we're never going to be able to. How are we going to tackle this whole journey? How are we going to go with this journey? Then slowly, like today, I think we're in such a good shape. So that's really important, I think. Just keep hanging in there. So now that I'm getting a clear idea on what makes the right support worker and the kind of training and personality that families are looking for, I'm shortly going to start recruiting for my next study, which will be interviewing support workers who provide in-home or community support, or health carers who provide respite at very special kids, so I can hear about their experience with providing respite care to children with severe neurological conditions. I'd like to say thank you very much for inviting me to speak today. Thank you to my supervisors, Professor Fiona Newell, Dr. Jenny O'Neill and Dr. Monica Cooper from the Children's Hospital, to my awesome lived experience advisors, who includes our very own Ellie, to Noah and his family for giving me permission to talk about them today, and to the parents who've been involved in my study. And if anyone wants to take part in my study, you're more than welcome to email me.
Thank you so much, Ingrid. That was amazing. Do you have any questions at all? Yes, we do.
Thanks, Ingrid. Are you able to interview the NDIS workers who don't seem to know what they're doing?
That's a good question. That's what I'm hoping to do for my third study. We're talking through it at the moment if the NDIS will give me access. So my idea is to do it in a way that's not too confronting, but more to present maybe some different scenarios, like, a child scenario that a family might put together to apply for respite, and then ask assessors how they would make decisions about like what sort of hours to allocate and what they might ask. And then if I can compare that across different assessors. And then I'm also thinking about comparing that to, so at RCH, we have the complex care program, where if you're at the right level, a tier 1 level, then you can get allocated some support worker hours, and they have a process for assessing that and allocating hours. And it would be interesting to see medical, nursing and social work assessments of how many hours to allocate versus maybe NDIS assessors, and then compare the two. So that yes is my plan.
Yeah. Any other questions? No, and I think some of the information you've presented today actually ties in.